for initiating and really masterfully organizing this series of webinars. We were very pleased by how many of our colleagues and friends and practitioners around the world joined the last session, which shared experiences from Asia. At that point, I think the idea was born to really continue with this series, particularly as today we are still seeing focus in majority on macrobiological, epidemiological, and public health responses. But there is a tremendous interest in the health aspects.
Sorry, Irina, you have to unmute yourself. I have to put mute all because people started to talk. I don't understand this, so I put mute all. Please unmute.
Okay, thank you. We are now seeing some segmentation between the countries based in large extent on their epidemiological picture and their response. And so some countries are faring better than the others and are charting their own paths. And I think these experiences are really invaluable for all of us who are trying to work with countries around the world to ensure appropriate response. At the moment here at the World Bank, I am the member of the steering group for P4H from the World Bank. We are supporting in this area about 100 countries and are collaborating across the world with other institutions and countries on a set of responses. So I am looking forward to hearing experiences of Germany today in particular. Germany, as you may know, was one of the founding members of the P4H network on health financing and has been an incredible supporter and leader in this arena and has certainly participated very actively in the P4H network. I will not spend more time. I will connect with you all at the end in time for a wrap up. But now I would like to hand over to Olivier to do a proper introduction of our distinguished speakers today. And once again, thank you all for joining and thank you to our discussant and participants as well. Thank you, Olivier. Over to you.
Thank you, Irina, very much for your introductory words. Before Professor Dr. Lauterbach will start his presentation, let me introduce him to you. I mean, certainly anyone in Germany would know him as he's a very high-profile deputy and frequently appears on talk shows and reflects on health systems issues and also recently also on Corona, obviously. Professor Lauterbach studied human medicine in Germany, in Aachen, and at the University of Texas in San Antonio, and University of Düsseldorf, where he graduated. He also studied health policy and management as well as epidemiology at the Harvard School of Public Health in Boston, graduating with a Doctor of Science in 1992. From 1992 to 1993, he held a fellowship at the Harvard Medical School. Since then, he has been director of the Institute of Health Economy and Clinical Epidemiology at the University of Cologne, and he was appointed adjunct professor at the Harvard School of Public Health in 2008. He was a member of the Council of Experts advising the federal government on developments in the German healthcare system from 1999 until he was elected to our parliament, to the Bundestag, in September 2005. He was a member of the Rurup Commission, a committee of experts that was established to review the financing of the social insurance system. Professor Lauterbach made his entry to the German parliament, to the Bundestag, with a direct mandate by winning in his electoral district, Cologne 4. So he is member of the parliament since 2005, and he served since then also on the health committee. He also, appointed by the Federal Minister of Health, Hermann Gröhe, he served as a member of an expert commission on the reform of Germany's hospital care from 2015 until 2017. As you can hear, we have really a truly exceptionally placed expert to share and to reflect on the German healthcare system. So please, Professor Lauterbach, go ahead with your presentation. Just wait a moment. I will now display your slides.
Perfect. Well, thank you, first of all, for having me on this important meeting, and thank you for introducing me. I'm currently very much involved in dealing with the Corona crisis, and in my presentation, I will start in giving a short introduction to where we are currently dealing with COVID-19, and then I will deal with the German healthcare financing Please go to slide number 2, Oliver.
Yes.
Where I introduced the corona chronology. We had our first case of COVID-19 coronavirus infection in January 28, and about 1 month later, March 1st, we had 100 cases, 100 infections confirmed in Germany. So at that time, we immediately recognized that this would be a pandemic that would also, let's say, hit Germany heavily, and we introduced measures to confine the spread of the disease as of March 1st. March 1st, the Federal Minister of Health recommended that all events with more than 1,000 people in Germany should be cancelled. About 2 weeks later, on March 13, we came up with the largest crisis package that we ever put together. The federal bank KfW, for, let's say, state development, came up with a rescue operation of 500 billion euros in order to, let's say, provide economic support for small businesses and large businesses. And we also immediately introduced an unemployment benefit package that would pay for everyone about 2/3 of the wage who was temporarily put out of work. In March 16, so basically 2 weeks after we had 100 cases, we closed down Germany with a fairly rigorous lockdown. The lockdown was not as rigorous as it was in France or Spain or Italy, but was much more rigorous than the lockdown in Sweden. We basically closed all bars, clubs, discotheques, pubs, theaters, operas, concert halls, museums, cinemas, leisure and animal parks, playgrounds, and so forth. So all public life was closed, but people were permitted to go outside. They were permitted to leave the home. They were permitted to basically meet with family members, and meetings with 2 people in public were permitted. We came up with a recommendation of 1.5 meters, roughly speaking, 6-foot distancing, social distancing. No masks at that point were worn in Germany, but this was the basic structure of the lockdown. The lockdown was heavily supported by a finance package, which made it possible for people to stay home, to either work in home office or to not work at all. Everyone who lost his job temporarily because there was no business and business was closed, was provided 2/3 of net income of income for an unrestricted time frame. So therefore, no one had to go to work in order to survive. No one had to go to work in order to, let's say, not lose the job. All jobs were basically secured, and public money was used in order to come up with a lockdown for about 1 month. I'm not going through the details of the lockdown. We can basically skip to page number 4. We can go to page number 4 now. The lockdown in general lasted for about 1 month. So it lasted from March 16 to April 20, roughly speaking 1 month. After 1 month, we, by that time, had been able to reduce the number of new cases considerably, so that we were able to basically ease the lockdown for the public. And we were roughly having about 1,000 new cases in Germany. We have 80 million inhabitants, so 1,000 new cases per day was the number of cases that we believed we were able to trace without a tracing app. That is the situation as of now. On page number 6, please go to page number 6. You can see that the lockdown worked fairly abruptly, and that we were able, as were Spain, Italy, and France, we were able to reduce the number of new cases considerably. We have less than 200,000 cases in total by now, and we on average have between 700 and 1,000 new cases per day. The R value, the reproductive value currently is roughly speaking 0.9. So we have less than one new case for all cases that are infected, currently infected. And we have been fairly successful in, let's say, reducing the COVID-19 death rate. If you go to page number 7, please go to page number 7. Here you can see that Germany did fairly well in reducing the number of deadly cases. The fatality is lower than in other European countries. In total, we have 8,000 people dead by now. That means that 1 in 10,000 Germans has died from the disease so far, and our, let's say, fatality rate is roughly speaking in the order of, let's say, 4 to 5 times lower than in Italy, France, and Spain. That can be explained because we were lucky to be able to come up with our lockdown before many fatal cases had happened. We were able to contain the number of new cases, that all new cases could be treated in high-end, all-out, highly qualified tertiary care centers. Our hospital system was at no point of the disease overburdened, overflown with cases, so all new cases were treated according to the highest, according to, let's say, the standards that are, let's say, unlimited standards. So we were not in a position to basically restrict the access to care, and we immediately tried to test as many patients as possible. On average, we were able to test about 400,000 patients per week, and we have a testing capacity as of now of more than 1 million tests that we could do per week, but we are not doing these tests because the number of new cases has gone down to 700 to 900 cases per day. On page number 8, you can see the daily confirmed COVID-19 deaths, and by now we have a death rate which is lower than 100 deaths per day. So we have managed by and large to contain the disease, at least as of now, and we are trying to prepare for, let's say, avoiding a second wave in the fall because we have substantially eased the lockdown. On page number 9, you see basically what we try to do in the future. We will have mandatory mask wearing in the public and also in public transport and in shops. And we have, let's say, we are preparing a tracing app, which will be a decentralized tracing app that will make it possible to follow up new cases and new spreads of the disease more quickly than we currently do. And we will invest in massive testing, in particular in schools, in hospitals, and also around new cases. So that is the strategy that we follow, which you see in this triangle: wearing masks and social distancing, testing, and the tracing app. That is how we try to prevent a second wave in the fall. I come to the second part of my presentation. Please go to page number 10. On page number 10, you see the general structure of the German healthcare system. We spend about 50% more in terms of absolute per capita expenditure than the OECD average, but we spend about half as much as the US. So we are somewhat spending-wise between the OECD average and the US in terms of total spending. In terms, next page please, page number 11. In terms of, let's say, the health expenditure as a share of gross domestic product, we spend about 11% of GDP on healthcare. This compares to 8.8 for the OECD countries and 16.9% in the US. So we are again here somewhere between the OECD average and the US. And if you go to the next page, please, page number 12, we have fairly low out-of-pocket payment. Most of the payment is paid by, let's say, mandatory contribution to sickness funds. We have public sickness funds, social sickness funds that are non-profit organizations, which are comparable to, let's say, health insurance schemes, non-profit health insurance schemes. They have a mandatory universal benefit package, and this benefit package is a fairly comprehensive benefit package. It covers inpatient care, outpatient care, long-term care. It also covers drugs and medical devices, and it is fairly comprehensive in comparison to other European countries, and in particular in comparison to the US. If you continue to go to page number 13, you see the general structure here again. We have 82 million inhabitants. Of these, 70 million are insured by the public statutory health insurance system. This is a public system. It is not a tax finance system, but it is a system which, let's say, uses mandatory contribution rates. The contribution rates are income-based, roughly speaking, 15% of income. Half of this is paid by the employee. The other half is paid by the employer. So it is basically a solidarity finance system where contribution rates depend on income and are paid 50% by the employer and 50% by the employee. On top of this, we have also a private system. The private system is typically the system for state employees and for, let's say, a couple of, let's say, entrepreneurs. It covers about 10% of the population, and I'm not going to cover this. You are only eligible for the private system if you are a state employee, a civil servant, or if you are a self-employed person, or if you earn above a certain income limit. But 90% of the people in Germany are publicly insured, and there is no major quality differences in the treatment and the coverages between the public system and the private system. On page number 14, you see the general system of our social insurance system. Our social insurance principles are based on 5 pillars. We have a retirement pension insurance, which is mandatory, then the healthcare insurance, which is mandatory, a long-term care insurance system, accident insurance, and unemployment insurance. Today, as I've already pointed out, salaries determine the contribution rate. So low salary means low payment, as you can see on page number 15. Dependents of members are eligible for the same benefits. For the unemployed and the welfare recipients, public funds pay, and we have a highly developed infrastructure, no waiting list. We do have an aging society, and we do get a lot of innovation, so the costs will be rising in the future. But currently the system, at least in the opinion of most Germans, is working reasonably well. We have about twice as many intensive care beds and intensive care facilities than European average. That was a major advantage in the COVID-19 crisis because of our, let's say, high density of hospitals in general and our even higher density of intensive care units and intensive care doctors. We were in a position to basically provide ventilation support and all-out ECMO treatment and ARDS treatment for all COVID patients that were in need of this. We go further to page number 17. How is the benefit package determined? How does this work? Well, we have a board of doctors, hospitals, and sickness funds, and they negotiate the benefit package. The benefit package by law has to cover all treatments that are shown to be cost-effective and evidence-based medicine. So whatever treatment comes to the market and can be shown to work according to the standards of evidence-based medicine and are reasonably cost effective without there being an official threshold of cost effectiveness has to be paid and has to be included in the benefit package. The benefit package is improved on a basically monthly basis. So all new drugs, all new treatments that come to the market and show superior value and benefit in comparison to standard treatments have to be included and have to be covered by the sickness fund. That holds for hospital treatment as well as drugs, as well as ambulatory care treatment. On page number 18, you see the distribution of expenditures according to the sectors. The biggest sector is the hospital sector, covering by and large 1/3 of the total expenditures. Drugs is about 1/6, and ambulatory care is also about 1/6. And you can see on the pie chart the remaining different parts of the benefit package. Currently, the system is running a small surplus, but this may change because the system does have this disadvantage that income to the sickness fund depend on how many people are in the workforce and their income, their general income. So due to the COVID-19 crisis, the income, the revenues of the sickness funds will decline in the near future. That is a problem, and we will basically cushion this with public funds, and we have just last week passed a law that will help the sickness funds to survive this income crisis. But we have a fair amount of liquidity reserve, and as of now, Germany, in terms of total debt, is doing reasonably well. Our total debt of the general society is about 60% of GDP, so this is well below European average. So in that sense, as of now at least, the healthcare system in Germany is not at an immediate risk of, let's say, shortness of funds. In the long run, this will obviously change, but we hope we are in a good position to master the corona crisis and also to master the aging of the society in the next decades to come. This is the short presentation that I wanted to share with you. If there is any questions for you, or if you are interested in any additional information, please let me know immediately. I'm looking forward to your questions, and also beyond what I've just told you, to beyond my short presentation here, and beyond the opportunity which I'm privileged to have with you today. I'm always available to you by my parliamentary office or by my institute at the University of Cologne or my Harvard office. So thank you so much for your attention, and I hope you could hear me well. I could unfortunately not see you for technical reasons, but I'm looking forward to your questions and your comments. Thank you, and I turn it back to Oliver.
Thank you very much, Karl. This was a very clear presentation, and also I was mostly able to click on the right time on the adequate PowerPoint slide. So I think the messages have come across very clearly. Also, I found it interesting, but I will not go into reflection now, that you also looked into issues like social protection and overall debt status of Germany, which of course also play a factor in the resilience dimension. A question has already come up from Joe Katzin, but I would like to proceed actually with the next presentation of BMZ, of the German Ministry of Development Cooperation. It will be a short one, and then hand it over to the discussants, Melita Jakob and Amanda Glassman, to reflect on your presentations. But can you stay with us for until the end of today's webinars? Otherwise, I would allow for a direct round of questions. Can you stay with us, Karl?
I can stay with you. I'm interested in what you have to say. Thank you so much that you are with us, Melita and Miranda, and looking forward to your presentation. I join you.
Okay, great. So, you will have the possibility of answering questions then towards the end, hopefully. Now, let me go to the other presentation. on behalf of BMZ, Ruth Schumacher. Dr. Ruth Schumacher will present. She's the project leader at German International Cooperation at GIZ, and leading the global project on universal health coverage, including also, amongst others, the contribution to this network of P4H, but also she's heading the special task force on pandemic, which was created actually after the Ebola crisis. The next presentation of BMZ and Ruth Schumacher. Ruth, can you please unmute yourself and start with the presentation?
I muted myself. Hello, everybody. This is Ruth from Bonn in Germany. And this is a very short presentation to give you an insight on what the German government is planning or has been doing already in providing support for least low and middle income countries in times of COVID-19. It's a very short presentation because, as far as I understood, the main focus was on the German response, that is to say on Karl Lauterbach's presentation. So I'll try to keep it short. But I think it rounds the webinar quite well up. Please go to the next slide. This is just to give you a very rough oversight on the German development assistance contribution, which has been going up from year to year, so continuously high, and Germany is the third largest donor in health overall. Next slide, please, Olivier. This is an overview on the bilateral and regional programs of German bilateral cooperation in health as of 2019. So you can see we have a strong focus on Africa and Asia, much less on South and North America. There are some components in health in America, but the main focus of health programs is in Africa and Asia. Next slide. So BMZ's bilateral and multilateral engagement in health to understand the COVID-19 response. I give you just a rough overview on the context. There is a new strategy which is called BMZ 2030, which has been put forward this year by the minister. And it aims at making German development cooperation more effective and strategic, and is quite strongly focusing on multilateralism. The health system strengthening and UHC will go through, though, as a commitment according to the SDG 3 agenda. And however, this is seen much more than in the past as part of the multilateral engagement of German development cooperation and politics. Probably most of you have heard about the Global Action Plan for Healthy Lives and Well-being to achieve the SDG 3. And this has to be seen as an overheading umbrella, also as the COVID-19 response is concerned. So the German politics aim at a very well-coordinated global health architecture response. Part of this is, of course, strengthening the collaboration with WHO to support its leadership and coordination, not only as pandemic preparedness is concerned, but as a leading key organization for coordination of partners in development politics. There is a continuation of bilateral health programs. This was argued upon in the past months as this focus on multilateralism became clear. But however, looking at the COVID-19 response, there has been a new focus on bilateral health programs, while at the same time strengthening the linkages to multilateral engagement. And a new focus in BMZ 2030 strategic approach is One Health, and I'll come back to this. One Health as an approach, a mainstreaming approach, which looks at different sectoral approaches, such as the health of the environment, health of veterinary health, and especially looking at how can we avoid that zoonosis spring over to mankind and produce and trigger new pandemics and epidemics. So One Health approach as a central element of pandemic preparedness. Next slide, Olivier, please. So now looking at the COVID-19 response, there have been, as part of the immediate responses, two branches. One is the immediate bilateral and regional response, and on the other hand, the response as part of the multilateral engagement. Here on this slide, you see the bilateral and regional response. On the one hand, health funds which have been reprogrammed as part of the bilateral engagement, as countries Cambodia, Cameroon, Ethiopia, Kyrgyzstan, Cambodia, Malawi, Nigeria, Nepal, Liberia, Tajikistan, and Togo, but also as regional programs in the EAC and ECOWAS are concerned. And these very fast responses were based on quick reaction of these bilateral programs, which have answered very quickly on the urgent needs in the countries where they are active. Responses asked for by the national governments, and have, together with the BMZ, made it possible that health funds could be reprogrammed very quickly towards the COVID-19 response in these countries. So many of these activities have already started and have very quickly put forward diagnosis centers, protective equipment and trainings and so on. There's also the epidemic preparedness team, which is actually part of our global initiative, of which I am part. And these are, please go back to the other slide. And there have been very quick missions as asked for by the respective governments, especially with a focus on equipping the diagnostic capacities of the countries to diagnose as quickly as possible the virus, and to get the response and contact tracing on board. So there have also been 58 million euros of humanitarian funds reprogrammed for broader support going beyond health, including water and sanitation, nutrition, education, but also for topping up the fast epidemic preparedness team, of which we have been talking already. Next slide. As for the multilateral response, there have been reprogramming of money for the Global Fund. You may know that Germany is one of the biggest donors for the Global Fund. And the Global Fund has put forward time-bound COVID-19 reaction mechanism of $500 million and 5% of existing HIV, TB, malaria grants have been made eligible for reprogramming towards COVID-19. Also, Gavi, the Global Vaccine Alliance, 10% of health systems strengthening program titles are eligible for reprogramming, and the BMZ announced a topping up of the German contribution of 600 million euros in the time period between 2021 and 25. And finally, the Pandemic Emergency Financing Facility, located in World Bank, and there has been quite an a big amount of money, nearly $200 million dispersed through the insurance window in 2 tranches. Next slide, please. So this is actually the last slide before putting forward some of our questions to the community. And this is the overall package, which goes far beyond health, and which is a €1 billion package of the medium-term COVID-19 response through the redirection and also additional funds from BMZ. And besides health and pandemic control, of which we have been already talking, there are other focuses like food security and basic food services, stabilization of fragile regions affected by displacement and refugees, social protection securing jobs in global supply chains, additional economic support for enterprises and key industries such as textiles and tourism, government liquidity, international cooperation. I will not go into details of these different columns of the package, just to give you an idea of where the German response goes far beyond the health response as COVID-19 is concerned. And on the last slide, you have some questions, but I would suggest that we first go into the discussion on Karl Lauterbach's presentation. Our questions to the community is what role for the One Health approach to play. What are your recommendations to us as a sector initiative, but also to BMZ as the One Health approach is concerned, which is a very ambitious approach actually. How to better link bi- and multilateral engagement, which is a key discussion area in German development cooperation these times, and what role for a network like P4H to play in this overall picture. Thank you very much.
Thank you very much, Ruth, for this additional presentation on what Germany is doing in the international cooperation arena. And I think, yesterday also Merkel speaking, our Chancellor, or the German Chancellor, speaking to the World Health Assembly, really highlighted in her speech the importance of continuing to invest in health system strengthening for really also building up future resilience vis-a-vis pandemics. So this, just to also say this, World Health Assembly also this year full of surprises with the 2 billion announcement of China. So we all stay tuned on this, I guess. Now, there were already a couple of questions coming up. Some have been answered in the meantime by the presenters as we go, I see. And I think some of them have been well noted also by the discussants. So without further ado, I would like to hand over the next the next contribution to Melita Jakob from the World Health Organization and responsible for the Euro region. Melita also graduated from Harvard School of Public Health, as far as I'm aware, and she's been overseeing the WHO Euro region and health financing for really quite some time. And in this, she has a unique overview of what the health financing challenges are, both for high-income countries, such as Germany, and what potentially other countries can learn from this, but also what the issues are for low-income countries, as Tajikistan, for example, is also part of a regional portfolio. So with this, Melita, I would hand over to you, and also just an announcement for the discussants. We are quite sticking very well in time, so you can take your time in reflecting and answering questions, because we are now we have enough time for really going into the discussion. Thank you. So Melita, over to you, and please unmute yourself.
Yes, thank you very much, Olivier, and hello and a big warm welcome to everybody. Karl, it is so nice to be in touch with you and cross paths again in this unexpected way and forum. So we here in WHO Regional Office are really admiring Germany's response to COVID-19, both in terms of the public health response, but also in terms of access to services. And in particular, we are all very eager to unpack the causes behind the low mortality rate. So your presentation was very exciting for us, and there is much to learn from. I'm going to comment from the perspective of countries that are less well-resourced and perhaps have a less well-developed health system than Germany does. So from the perspective of eastern part of our region. And I have 4 main points to make, and I'm sure Amanda will echo some of them. The first one is, it seems that one of the critical lessons from Germany is that sufficient funds for essential public health functions must be available to respond well to COVID-19. And this is something that our blog or Health Financing Global Technical Guidance emphasizes. When we look at countries where I work in, health systems are much less well funded, operating at 3, 4, 5, 6, 7% of GDP. And within that, public health action in particular has been underfunded for decades. So it is very, in the first part of the response, what we have seen is that even these countries have made resources rapidly available, but those resources have gone into creating acute and intensive care surge capacity mostly. And as countries are coming out of the lockdown, it's very important to ensure that public health surge capacity for testing, tracing, and isolating is also available. But in this part of the world, they're not so well available. And then the question is, how do we change these spending patterns very rapidly, very rapidly ensure that there is public health surge capacity, and how we resource that? And here is, I think, what some of the warnings that I think as countries are now heavily investing to make acute and intensive care available, we have to make sure that this short-term response does not remain a long-term spending pattern, because we will be seeing ventilator cemeteries, to use a term I just recently heard. And we should not forget about our long-term agenda in health system strengthening of primary healthcare and public health capacities that are the cornerstone of good pandemic preparedness, but also to move towards universal health coverage. I saw in one of your slides, Carl, that Germany indeed is now looking ahead to create this public health surge capacity. And you noted that teams of 5 per 20,000 inhabitants are going to be created or are being created. And if you could speak a little bit more about this after my comments, that would be really helpful. And it also ties in with a comment in the chat line from Michael Borowitz from the Global Fund of how you're thinking about it, how you're resourcing this, and whether you're using digital contact tracing applications. So my second comment would lead to how we ensure coverage and how we fund coverage for countries. And it is quite clear that full population coverage, which is well financed, is essential at times like this, where health-seeking behavior intensifies, to make sure that nobody experiences barriers to seeking either preventive action or treatment when they need it. And it seems Germany has handled this incredibly well. However, there are some dangers with payroll tax finance and employment-based coverage when we look at less mature social health insurance systems. And there are a number of issues here. The first one you mentioned, that there is a very rapid revenue shortfall when the economies come to a stop, employment declines, salaries decline, and there is just simply a revenue shortfall for social health insurance agencies. And in your case, it sounds like Germany has handled it from reserves, but of course, not all countries have reserves. The extent of reserves and how long they last depends on the magnitude of the crisis. And the general budget needs to step in to cover some of those revenue shortfalls. But beyond the resources, what happens with those who are not covered or lose their coverage? And when we see not population-based coverage mechanisms that obviously excluded groups. In the case of Germany, possibly the excluded groups is quite small. And in Western Europe, we think about non-residents, we think about asylum seekers, we think about migrants. But this can be much larger in middle-income countries or lower-income countries, where the excluded population is much larger and includes the informal sector and people with loose attachment to labor markets, who are the most vulnerable to this economic decline, and they will be the first one to lose their coverage in these type of schemes. So I think it's a question to all of us of what can we do in the short term to mitigate loss of coverage. How can we ensure that people who have temporarily lost their coverage retain it and retain access to services? But in the long term, I think, to be provocative, it really raises a long-term issue and a question: does it really make sense for countries that don't have it to move towards universal coverage with employment-based coverage and payroll tax-based finances, which is so vulnerable to economic shocks, or whether it makes more sense to think just general tax-based financing and covering the whole of the population? The third area I'd like to address is related to strategic purchasing. And perhaps, Carl, you talked a little bit less about it, but I think it's of interest to all of us, and there were a few questions in the chat line. One of our hypotheses going forward is that countries that have had a strong strategic purchasing function and could rapidly allocate funding to new priorities and resource new ways of delivering services were able to respond to the COVID-19 crisis better. And a number of issues surface here based on other countries' experience. First, you need to finance the surge. And in the case of Germany, you had excess capacity available, but this is not the case in other, even Western European countries that have a much leaner hospital system, and they needed to create surge capacity by drawing in unexpected resources from the private sector, but also repurposing facilities beyond the health sector and transforming hotels into healthcare facilities or establishing camp-style hospitals. And rapidly financing this is a very important aspect of being able to respond to the outbreak. To the extent that COVID-19 is going to stay with us for the next 12 to 18 months, and we need to remain elastic and flexible in our response, I think it's important to think how we can scale up and down the acute and intensive care capacity that might be needed for further peaks. So thinking about this, what was the contracting modality that Germany used to fund the acute surge capacity? And Michael asked in the chat line whether you developed a specific DRG or whether you're using another mechanism such as a block payment for beds or a block payment for preparedness. Within strategic purchasing, I think for me a really interesting question is we are seeing an unprecedented reconfiguration of non-COVID related health services. So obviously countries have canceling, postponing electives, but even more importantly, they're moving the delivery of essential health services to phone-based and telemedicine platforms with very rapid adaptation. And the question is, how do we pay for this? How do purchasers pay for it? And how do we reflect it in the statistics? We are seeing in a number of Western European countries that the contracts are accommodating this, paying the same amount for a phone-based or telemedicine consultation for the same topic as physically would have been. But for example, do we include this in capitation payments, et cetera, et cetera? I think that's a very interesting question. I don't know if Germany has any experiences on this. The third one relates back to my first point. How do we pay for public health surge capacity? Because we're going to now really need to multiply the tracing abilities. How do we pay for that? And I think quite a few countries would like to know specifically the answer of whether you had a special approach with private providers. And then I come to my last point, which is related to governance of the system. To operate health systems in this COVID world, the complexity of governance mechanism has really increased. And that is because the COVID-19 governance mechanism, a whole of government governance mechanism in most countries. And within this, what's situated is the governance of the regular service delivery network that's organized national, regional, district, etc. level. And how does that link to the governance of health financing, especially when the reconfiguration of services is driven from a public health services perspective, and how we link that? what we're seeing in our region is there are a few countries where the governance between service delivery and health financing, or let's say Ministry of Health and the health insurance or purchasing agencies, is not particularly cordial or partnership based, and they have a much more difficult time to respond efficiently and ensure proper funding is flowing to the reconfiguration of services that are needed. So if you have any lessons on that, I think that would be really helpful. This would be all from my side. And what I will now do is, in the chat line, I'm going to share with you all 3 resources that you might find valuable. One is our global technical guidance on health financing. The second one is the technical guidance for the European region, where you will find some of my comments very well reflected with some country examples. And I will give you the link to the European Observatory that has a response monitor where you can look at the responses documented of different countries. Thank you very much.
Thank you very much, Melita. This was really informative and very, broad in its coverage and depth. And personally, I experienced some fatigue from all these digital meetings. But again, this today shows it would have been very difficult to bring all of us together in real presence, and would have made much more planning necessary. So it was fantastic you could join. Thank you. So I appreciate you already picked up on some questions from Carl, but you also gave him back some questions. There are more questions also to Carl, but I suggest now to move over to Amanda Glassman, and then we'll see which questions are still open. And we have time also. I can foresee that we will have time to go through the question. There's also a rich set of questions actually going back to the presentation of BMZ, some are intellectually quite challenging actually. So I'm looking forward also to this discussion. But for now, over to Amanda Glassman. Amanda Glassman is the vice president of the think tank Center for Global Development, based here in Washington, D.C. And she's one, at a global scale, really leaders and thinkers on health financing. And recently, the Center for Global Development has also produced a lot of analytical think pieces on what the COVID-19 crisis means also for low and mid-income countries. So I'm really glad that Amanda agreed to also join this session, and also she also seems to know Carl and Melita. So Amanda, over to you, please. And thanks for being with us.
Thank you so much, Olivier. And sorry that I have to wear my gamer headset, but it will improve the quality of the sound. And wonderful to be here with Dr. Lauterbach and Jakob, because I see that we are all graduates of the same university. So that is probably a sign that we're not diverse enough. But in any case, thank you so much for the opportunity to speak today. I wanted to start with one point that Carl made about the German response. He started with all jobs are secured, income from employment is secured, and that enabled people to stay at home and observe the lockdown. And I think, of course, we're from the health sector, and we always think of a health response first. But if you think about what is the main obstacle to uh, reducing exposure in low and middle income countries, it's the impossibility of not going into the labor market to work to gain income, because so many people are in the informal sector. So many people depend on that labor income to be able to survive. Um, and the scale of the assistance that was provided in Germany for this purpose is very large. I think I read somewhere that Germany's virus aid is more than half of the total expended for the entire rest of the European Union. It's significant. And yet they have a quarter of the deaths of France despite this more flexible lockdown. And I suspect it is around this issue on the ability to stay home and to decisively lower the transmission rate. And I'd be interested to know what share of GDP is going to that piece of the response, so people have a sense of what the magnitude is. I mean, I wonder, of course, I know that cash transfers and other kinds of social assistance interventions have increased enormously. There's a colleague of yours at the World Bank, Ugo Gentilini, who's putting out a weekly update of all of the social assistance and cash transfer programs around the world. and has found a doubling of their coverage, but they started from an enormously low base. So I guess my question is, do we need to supersize the World Bank or like organizations to be able to finance cash transfers for a very large share of the population for a time? It's expensive, but it's not enormously expensive because we're talking maybe 8% of the GDP of these countries, which is what the sort of order of magnitude looks like in the EU. Is that something we have to think about for low and middle income countries as part of this response? Maybe as a starting point for the response. It's just food for thought. A second point that Melita also picked up had to do with how the government is acting to assure that their employment based health system continues to operate and be in good fiscal shape given the contractions in employment. And interesting that even though the schemes, the sickness funds are operating with a small surplus, that there is legislation that has been put in place to assure stabilization and smoothing of the financing to the system during this period. And I think it's worth thinking about how we might need, this obviously, even for those countries that do have reserve funds, and not many do, unfortunately, as part of their social health insurance systems or their health system arrangements. And so they are going to require that the central governments consider that kind of anti-cyclical spend into the health system. And it requires smoothing. I just think the magnitude of this collapse in economic activity is really going to require extraordinary measures. And we might need to think as a global community about what is the size of that necessary response. How many countries did have reserve funds that were ready to operate? We looked at this issue now 3 to 4 years ago in the context of looking at benefits plans and how they were being financed. Very few countries really have appropriate reserves in place to be able to deal with such a contraction in revenues. And so we do have to look to these governments, to central governments to put in place legislation. It would be great to see the German example. Another sort of related issue is what to do in systems where a lot of people, even the poor, this is not all systems, but they're seeking care in the private sector for things like fever, for things like institutional delivery. Um, there is this interesting opportunity right now, just inspired by the German system that, you know, contracts with private providers, either physicians who are general practitioners or other kinds of providers. Is this an opportunity to contract providers into one system? We've seen some interesting things happening, for example, in Mexico and in Spain with the contracting of private facilities. Is this an opportunity to govern this a bit better? Of course, it's not great to talk about a terrible epidemic as an opportunity for change, but we do have to look at those situations. Just because in many countries, um, the private system was operating completely outside. When we see the collapse in demand, we're likely to see those private providers go under. Um, do we want to lose that capacity to the health system? Is this an opportunity if we are going to enable countercyclical spend on the public side to bring some of those providers in? And I mean, just to give you, depends on the country, of course, but I was looking at some recent DHS data, and 80% of fever and cough treatment in Cambodia across urban and rural is in the private sector, or 50% of institutional deliveries in Indonesia among the poor are happening in the private sector. So, it could be that there could be various things going on here, but I do think we have to think about what to do with those private providers during this period of huge contraction. A third thought is about the global institutions and how best to support countries to respond and set priorities. I've already talked a little bit about the importance of the social protection, social assistance piece as the public health response. Similarly, water and sanitation obviously is of great importance, and probably those two may come at a different order of priority even before we talk about the health system. And I'm really concerned about the ventilator cemetery that Melita was responding to, that she mentioned, and the lack of funding historically to public health. Even in a region, I worked for a very long time in the countries in Latin America, and public health never made it above 2% of budgets in so many cases. It is a just not operational system at this stage. It's underfunded. And the question is, how quickly can we scale that up? And how do we pay for public health? I think that's something that comes up in the comments section. In general, what has been happening, well, there's of course the vertical programs like immunization that are a big part of public health response, but many times countries just decentralize the public health budget down to municipalities and states, and they had varying ability to use the money as well, and we're sort of all over the place. So I do think we need to map what's going on with public health infrastructure in a lot of countries, and see how we might pay for rapid increases in the operativity of those kinds of programs. Finally, I'm really concerned about the data. There have been a lot of articles this week about how is it possible that sub-Saharan Africa has missed out on, or there's something about sub-Saharan Africa, maybe it's the age structure, maybe it's climate, but we're not seeing cases and deaths. And I wonder how much of that is due to just the totally inadequate reporting on deaths. The incompleteness, the very slow speed of reporting of deaths make it very difficult to understand what is happening. And even in Latin America, the reporting on deaths are coming from funeral homes, not from the health system. I think this is also, opportunity is the wrong word, but this is a moment when we really have to focus on the basics of the health system to be able to know what is going on. And then a final word about aid coordination. Does anybody know who's doing what in each country? It's hard to say. This is like the inevitable problem, except now that it's happening in every country around the world. So I mean, just be interesting to hear from the participants whether we are really joining up the response and support of developing country governments. Do they have sight of all of the different funds and pieces into their system? And back to Carl, I do want to know the answer to the question about what happens with routine health care, how to sustain services like basic immunization, what has Germany done? And then the issue of exposures and spread that's related to the health facilities. That's incredible that in the UK, 20% of cases are from exposures in health facilities, not even talking about care homes, but in health facilities. How is it that, did you avoid that? Were there special measures taken? Okay, I'll stop there, but thank you so much for the opportunity to participate in this discussion today.
Thank you so much, Amanda, for sharing your thoughts. And did I just hear that you launched today a new global institution called Global Fund for Social Protection and Basic Income for All? I'm not sure, but we are eager to hear. Okay, now there were from you, but also from Melita, a number of reflections and questions going back to Carl. I'm not sure if you, Carl, can actually see the questions that were put to you in the chat box. So let me just pull out maybe two. So one was also the question why Germany would have so many ICU beds in general. This was one. And I leave it with this because there are also many questions afterwards to BMZ. So I leave this with one, but we will definitely go through the questions and try to answer them. So now I'm unmuting you again, Carl, for reacting to these two discussants input. I'm not sure if you're user 3 or 6, unmuting the two of them and hoping that. Okay, please, Carl, go ahead.
Well, thank you so much for the presentations, Melita and Amanda, and also for the generous questions. I'll try to answer the questions that you posed. First of all, we in Germany understand very well that that this is a long-term dance. Basically, the strategy that we are following here is the famous hammer and dance strategy. So we are now in the beginning of the dance mode, and we initially even wanted to continue to the lockdown. I recommended that we continue the lockdown for a couple of additional weeks so that we would be able to come down to, let's say, 100 new cases or less per week. that would be, let's say, the strategy that South Korea has taken, but we opted against this. This is a long story, but nevertheless, we want to try to have the R value consistently somewhere between 0.5 and 0.75 at a fairly low number, at a fairly low total number of new cases. Roughly speaking, that would mean that at the end of the pandemic, if the pandemic goes on for 1.5 years, we will have a one-digit percentage of the population having been infected, but more than 90% of the population, we aim of not getting the infection before a vaccination comes across. So that is the strategy. We understand very well that this is only possible if you have, let's say, a well-accepted tracing app available by for the population, because the studies from Fraser and others in Oxford, but there's also similar studies from the University of Utrecht, they have shown that it is not possible with, let's say, manual standard contact tracing to get in front of the wave. You are always running behind the wave. So a decentralized tracing app, which is, let's say, a tracing app that does not use personal data, which is basically employed by an app on your smartphone, which is, let's say, capable to be run on all iPhones and all Android systems, a decentralized and anonymous app. That is what we basically rely on, and we will gear towards 5 per 20,000 contact tracers in the population. So for a district of 100,000 people, we will then have 25 contact tracers. Together with the app and with massive testing around the new cases, we believe we will be able to mount a public health response in combination with, let's say, high quality masks. We currently invest massively in the production of surgical masks of high quality and FFP2 masks in Germany, and we will most likely be able to produce more than 1 billion of these masks per year. We are currently building the machines. The machines are built in Germany in order to become self-sufficient in the production of high-quality, high-end masks for the population. So the public health strategy will be high-quality mask wearing in all public spaces, in particular in, let's say, at work and in restaurants and in shops and in public transport, to have contact tracing with a high-quality decentralized app, and to, let's say, invest in public health contact tracers, roughly speaking, 5 tracing people per 20,000 inhabitants. All of this is paid for by public money, which is for which we came up with a law. Taxpayer money. It does not burden the sickness funds additionally, but it is basically a public health response, tax funded by the government in terms of an emergency law that will last for as long as the pandemic lasts in Germany, which has no limit time-wise for the next 2 years at least. Where ventilators and so forth were available in Germany, and we bought 10,000 additional ventilators. So if we do have a second wave, we will have a total capacity of 50,000 ventilators available for 80 million people. That will basically be a very, and we will also have, let's say, ICU staff and doctors to make these ventilators operable. So we work with a two-tiered system here. We rely on the public health response, but if a second wave hits heavily, then we will have ventilators in place, and we currently, we have basically paid for 10,000 additional ventilators that are currently built in Germany and should be ready by the end of the year. You are right that there is a question whether, let's say, a tax-based system, tax-based system or contribution rate system is better in a crisis. Our experience, at least, was that, let's say, a contribution rate-based system, healthcare system, does fairly well in the crisis. We had, let's say, a very good experience with that in the financial crisis in 2008, 2009. We had good experiences in, let's say, the Euro crisis. Why is that so? Because whenever there is a major economic crisis, what the government typically does, the government puts out money, tax money, into the labor market. So basically a demand supporting labor market policy is what we typically do whenever there is a crisis. So that is then money that gets into the labor market immediately and indirectly ends up in the contribution rate. Because all the money that is put into the labor market, for example, unemployment money or short-term money or money, let's say, that is demand spending money, Keynesianism, demand spending money, supports the contribution rate. If our system was tax-based, then the tax base for supporting the healthcare system would be in competition with the support of the labor market. So whenever there would be a crisis in Germany, we would have basically a competition. Do we put money into the healthcare system or do we put it into the labor market? And that competition basically is this, let's say, decision we avoid in putting the money into the labor market, but having the contribution rate paid for by the contributions and by the labor market. So therefore, the money indirectly ends up in the healthcare system without being in competition with the direct support of the labor market. So I just wanted to point this out. This is a very long discussion. There is advantages and disadvantages to all of these systems, obviously. So this is well beyond the scope of what we can discuss today. But for reasons of fairness, I wanted to point out that at least our, let's say, experience in the crisis with a contribution-based system was that in the crisis it performs reasonably well and has not been cut because there is no budget cut. The government cannot cut the benefit budget, package. If, let's say, if there is a crisis, the benefit package cannot be cut by the government. The benefit package is decided upon on the grounds of evidence-based medicine and efficiency considerations by the sickness funds, the hospitals, and the doctors. So the government is in no position to cut the benefit package even in the time of crisis, and has to support everyone who is out of work in terms of then paying their contribution rate. There was the question who pays for telemedicine, because telemedicine is now, let's say, in high demand in Germany, and also has who paid for the extra services. Well, what we basically did, we supported the sickness funds with extra money, tax money, so that they were able to provide services, emergency services, beyond what they were typically providing at that time of the year. So, and we also paid for, let's say, services that were, let's say, not used, but could possibly be used, basically for the, what you would call the reserve services. So all hospitals were given 500 euros per day for, let's say, COVID-19 treatment, and there was additional money put into a system. It's a little bit of a complicated decision, but we made sure that telemedicine services have to be paid for by the sickness fund, and we supported the hospitals in making sure that their budgets would not be cut because of the COVID-19 crisis. Coming back to Amanda's question, first of all, I could not agree more with you that it is very important that the employees, they need money, they need support, financial support, in order to be able to stay home. Because if you have to go to work, if you have to take risks, if you have to spread the disease because there is no alternative, because companies depend on you or the companies demand you to come into work, and you have no alternative because there is no stay at home money available to you, no short-term unemployment money available you immediately, then you cannot really mount a public health response to the disease. I think that this is at least in part of what I understand was the problem in the US, because many people actually had to work. They had to use public transport at a time when it was already very risky to do so. So we wanted to make sure that no one had to go to work for financial reasons. And we made it quite clear that, that we would carry through with that as long as it would take, in order to make sure that no one would go in, no one would basically come to work, no one would use public transport and so forth for financial reasons. And the question was whether we should now have a discussion about the healthcare system, how to put in more private providers into the public system. We decided not to do that because obviously this is not the emergency in which we currently are. It's not a good time to have, let's say, a system debate, to speak about healthcare system reform in general. The people who are knowledgeable in the field and who have been involved in healthcare reforms in the last 10, 15 years or so, they are now involved in mounting the response against COVID-19. And this is not a good time, in my opinion at least, to discuss how we could bring in private insurers. But this is from the German perspective. What we made clear from the very beginning is that all private insurers and all private providers have to operate under the same rules as the public system. So it was made quite clear from the very beginning, and I myself was also very vocal about this in public speeches and in parliament and so forth, that it is impossible, that reason picking is not permitted to the private providers or the private insurers. So they were under an obligation by law to provide exactly the same services as the public system has to provide. Ultimately, I think prevention will become stronger. This is one of the very, very few blessings of this disease, this horrible disease, which puts at risk so many people and kills so many. But the value of public health interventions has become quite clear in Germany and I think in many European places. So therefore we will have much better pandemic preparedness plans in the future. We will focus way more on basic immunization. We will invest into public health facilities. We have decided to invest massively into the, let's say, public health services on a community level. Let's call this a community public health facilities. We will increase their wages and also increase the number of people working there. And ultimately, the question, Oliver, which you put from the floor, why we had so many ICU beds. Well, in Germany, ICU capacity has traditionally been high. We have a fairly expensive hospital system. We have the highest hospital density per capita in all of Europe, and accordingly we also have a very high ICU density. This typically also does not only come along with advantages. It is very expensive and it is let's say it's not uncontroversial, let's put it that way, but clearly in such a crisis it is very good to have, and it helped us because we were able to give high quality care, at least for German standards, for everyone who needed ventilation support of whatever sort. So from mask ventilation to intubation ventilation to ECMO treatment to ARDS treatment and also dialysis ECMO treatment. So all, let's say, high-end interventions for people with multi-organ disease and, let's say, lung failure, immediate pneumonia and so forth, we were able to treat them at least at the highest level of our capacities, and that helped basically to reduce the fatality. I think that this is one of the reasons why, in comparison to the number of cases we had a fairly low fatality rate. That may change a little bit in the future, but so far we have been doing well. And again, no one knows what a second wave is bringing. Then ultimately, the last question which came up is how will we respond to this in the long term, in the long run? Well, it is quite clear that we were hit unprepared, that we were lucky. The German population was very compliant with the lockdown because they saw the horrible pictures from Italy in particular. So it is, in my opinion, also fair to stress that Germany was lucky in the, let's say, in response to the disease, because there was a high awareness how difficult that can become, and the population was very eager to follow the recommendations that we put out, and we are now currently investing in all forms of, let's say, pandemic control, including support of companies, startups that, let's say, get into the vaccination business, that try to come up with vaccinations. We invest in bigger vaccine companies so that we have the facilities available if there ultimately is a vaccine, that it can at least be produced to the degree we need it for Germans in Germany. And there is also massive investment in testing capacities so that we will be able to do more massive testing around schools, hospitals. Coming back to the question why we didn't have a spread in the hospitals. Well, first of all, we did fairly intensive testing in hospitals, and number two, since our hospitals were never really over flooded with patients, because we had a reasonably limited number of new patients, and we were able to spread these cases over many facilities, there was a somewhat lower infection risk for the people in the hospitals and also for the staffers. But we had a couple of cases, but in comparison to other countries, we were lucky.
Thank you so much, Karl, for taking time to answer and go through the questions. I was sure that there would be some comments from Joe and others on your point of the advantage of the contributory-based system, and I was not disappointed because actually they made some comments in written. There's a rich discussion to be followed. We'll write these up, and perhaps we can even tease out something in written from all of this. So perhaps the key core message we heard today was really strengthening the public health system when building back. This was also a point made by Agnes Sukat. This is one, and one thing that occurred again to me today, we touched always a bit outside the healthcare system itself, looking into social protection, looking into overall governance arrangements within which these health systems operate, and also the way how governments steer their budgets. So I think if we talk about resilience, we need to really take a broader look also when teasing out lessons for the future. With this, we cannot, unfortunately, due to time is over, so I have left already. So the questions related to BMZ and German Development Corporation we will answer in written. And for closing, so from my side, I would already like to thank you all. I would like to give the word to Irina Nikolic, our chair of the session, for some concluding remarks. Thank you. Over to you, Irina, please.
Thank you, Olivier. Thank you, Karl, Ruth, Melita, Amanda, and all the participants, particularly those who have asked really great questions, and keep them coming. So building on, Olivier, what you've just said, I think we've heard excellent presentations of the both German system and the COVID response, both at home and globally. And I think we've heard about the importance of financing health, both in terms of health financing as well as in financing outside of health, financing the health of the people, whether that's through labor markets, through support for the compliance, which was so important in Germany, and so on. It's clear we have to shore up the basics, invest in health, and buy the right things. So I was quite impressed by the description of the comprehensive benefit packages that include long-term care in Germany and that work for people's needs at a time when they're needed. We also talked about the importance of all hands on deck. Countries, labor markets, organizations, that are global in its reach as well as regional and international collaboration. And we talked about adopting the ways that we work together. Ruth talked about BMZ 2030, and we would love to get into that a lot more. And I know that you will send the questions out so we can hear more about German strategy going forward. I think what is clear is that we will have to also adapt the way that we do our supply chains, that we manufacture PPE, that we invest in public health systems, but fundamentally also, I think as Carl reminded us, we are adapting our mindsets as well. And we're adapting them around the value of public health. Finally, we cannot do it alone. Reminders around One Health, role for the private sector, role for all the sectors outside of health, as well as for all of us practicing in health systems. And then, of course, importance of collaboration and sharing our experiences. We've heard from South Korea and China, from the Asian continent. We've now heard from Germany and European continent. Olivier, maybe over to you to say what the next one is. I think we might stay in European continent for the next one, but I don't want to reveal any secrets without you. Thank you again.
Yeah, thank you again, Irina, for these concluding remarks. And this is just to alert already, as Irina said, that the next webinar of this kind will be with France. And we are lucky to have a former Minister of Health that is willing to share experience of France. And we want to enter a more in-depth conversation also with some low-income countries in sub-Saharan French-speaking Africa. So stay tuned. And for now, I wish you a good day or good evening, wherever you are, and looking forward to seeing or hearing you at the next webinar. And we'll promise to send back answers to the questions that could not be answered. So thanks again. Have a good day, everyone. Bye.